So hello everyone, I'm Paul Glasziou, one of the co-founders of the BESI collaboration, and we'll get started in about 1 minute, but just allowing time for everybody to come in. So the order this evening, by the way, is I'll give a brief introduction, and then we have 3 speakers this evening whom Susan will introduce, but we'll leave plenty of time for questions and answers as well. So I might just wait another 30 seconds to make sure that everybody's had a chance to get in. Okay, so good morning, afternoon or evening, depending upon where in the world you are. I'm Paul Glasziou, one of the co-founders of the BESI collaboration, and this is our 5th webinar in the series of webinars, and the second last for the year. Just a brief background before I hand over to the speakers on the BESI collaboration. We started this a few months ago to foster more research into the behavioural, environmental, social and systems interventions that we didn't feel were being adequately addressed during the pandemic. And one of the things that we keep on the BESI website is this scorecard that looks at the number of trials that are going on, registered and reported for drugs, compared with those for the BESI interventions. And of course, it's more research that's needed than just the trials, but this was just a simple way of contrasting the amount of work going on for the two. And I've been looking at the breakdown of the countries, by the way, that have been doing the research, and Denmark and Germany are in the lead with 2, Norway 1, Guinea-Bissau has the large masks trial, which is just winding up now, China 1, Brazil 1, Australia 1, Canada 1, and 1 is actually a multinational study. So a nice mix from around the world, but a few important countries you can see missing there that I won't embarrass by naming them. So what is BESI? It's a global interdisciplinary and collaboration which aims to foster BESI research and its translation into evidence, policy and practice. So our primary objective is the research that focuses on reducing viral transmission to reduce COVID, to achieve zero COVID with the BESI. And in particular, keeping in mind that we would like to maximise the effects of the interventions while minimising the disruption. There's also a longer term objective, which is to reduce the likelihood and impact of future pandemics that we need to learn now during this one. And we also need to learn to help to build back better. So there's a number of activities that BESI has been doing. There's a BESI JISC list that some of you have probably signed up from, but the other thing is to hold this series of webinars. This is the 5th in the series, as I said, and there's a 6th one that you might note in your diaries, which will be on the 10th of December. And then we'll have a kickoff in January about the future of BESIs and your views. That will be a more interactive session. And we'll announce the date of that before the end of the year. Just one thing before we actually start the talks tonight is that there's a question and answer function. If I can get you to type your questions into that, we will monitor them. So please, as soon as you think of a question, you'll forget it unless you type it in. So type it in straight away and we'll monitor that and get back to those questions during the break periods. And also, if you could add your name and country, just so that we're aware of where you're from. And I'm now going to hand over to Susan to introduce our speakers for this evening. Susan.
Thank you. Well, I'm delighted to say we have 2 colleagues from Uruguay, a country that's done exceptionally well during this pandemic, and also a colleague from the World Health Organization to address us today. And we've asked the speakers to be somewhere between 5 and 7 minutes so that we can have maximum question and answer time afterwards. And we'll be hearing from our 2 Uruguay colleagues first. So first of all, I'm delighted to welcome Professor Dr. Henry Cohen. who is health coordinator of the Scientific Advisory Group that is appointed by the Uruguayan president to address the COVID-19 pandemic. And Henry is by background a professor of gastroenterology and holds many other prestigious titles. Henry, over to you.
Thank you for the invitation. Good morning, everyone. I'm very pleased to introduce you in short time our experience in Uruguay about COVID. Uruguay is a small country, but mostly with a little amount of persons living here. We are only 3.5 million, and the problem we have is a big dry border with Brazil, a country who has exceptionally high levels of COVID-19. As you may know, in March 1st, our government changed to a new political party. Only 12 days after, the first cases arrived to Uruguay, and the government took some early important decisions, as declaring a health emergency, establishment of mandatory quarantine for travelers coming from abroad, to recommend people to avoid crowded places, and the suspension of classes. The characteristics of these phases were mostly transparency in the communication with the population and the concept of freedom with responsibility. The most difficult decision for the president was no mandatory lockdown in a moment in which most countries were deciding that, and there was a high level of pressure from other political parties asking mandatory lockdown. The first month in Uruguay was marked by the physical distancing, strong stay-at-home directives from the government, but not mandatory, and with a massive voluntary response of the population. In relation with the tracing, testing, and isolation, initially the capacity was limited, the tracing muscle had to be developed on the fly, and the isolation, it was important because there is already a widespread availability of home medicine and the possibility of doing testing at home. So the question 1 month after was, can we open up? And the president asked the scientists, and he created this honorary scientific advisory group, which I have the honor to integrate with 2 other prestigious colleagues in Uruguay. One of them biochemist and the other mathematician. So this group worked in two fields, the health planning and the other, the mathematical models and data science. We also asked 55 pro bono experts in sciences in different fields to collaborate. And the main duty was to advise the government on the management of the pandemic, how to transit to the new normal, changing the message from stay home to sustained physical distancing. The decisions are up to the government. We only give some recommendations. And it was very important, the concept of no political interference. That's what the president said. We will move forward as much as possible, but we will go backwards every time we need, because health is still the most important.
Para adelante todo lo posible, para atrás todo lo necesario, porque sigue siendo la salud lo más importante.
So this group did some important recommendations. We worked under 4 criteria to resume activities: progressiveness, regulation, monitoring, and evidence-based. We did more than 40 reports, and the most important recommendations were, in early April, to reopening schools. We insisted very much on the non-pharmacological interventions. We also worked on the responsible use of public spaces. We recommended the government to increase Tetris and to put in practice new tests as serology, LAMP, and sequencing. And we also worked very much in the relations with media and in this way with the population. There were also other contributions from other scientists, especially in the local development of PCR tests in a moment in which the world couldn't sell to Uruguay because they were used in their own countries. And they also worked very well in sequences of viral genomes and the studies of wastewater. But Susan said that we were very successful, and we really were, but look the changes in the last 2 months. We moved from 2,000 cases until September 28, and in the last 2 months, we are close to 5,000 already. That was the last Saturday. The deaths are increasing, the lethality is still low, the mortality is still low, but there are much more patients admitted, 11 and now 39, especially in intensive care units. But there are also good things. We have a lot of tests, more than 10% of the population, and the positivity of tests in all the period is 1.15. Nowadays, it's around 2. Luckily, we are still dancing under control because we avoided exponential growth within Tetris capacity limits. New activities are opening, always under distancing protocols, but we have threats that abound. The border with Brazil, the arrival of summer, with people trying to come back to Uruguay to spend the holidays with their families, and that can lead to uncontrolled private gatherings. And also, as you know, mate is a national drink, and people used to share the same mate. And that is quite dangerous. But, you know, we have been doing well, but the equilibrium is fragile. You can see Costa Rica, a small country as Uruguay, up to June 1st, we were doing almost the same. Then Costa Rica went up, we stayed in a good position, but now, November 25, Costa Rica continues growing exponentially. We are growing not so quickly, but we have to admit that we are growing, and we need to take some measures to correct this situation. So finally, why has Uruguay been successful up to now? Because we have a relatively small population with a low density, with a good literacy group, universal healthcare coverage, including strong primary care and good at-home care, excellent scientists, and appropriate and timely decisions by the Uruguayan government at the very beginning, a synergy between the government and the scientific system that maybe is unique in our continent, a rapid response to coronavirus outbreaks, and finally, an unbeatable citizens' response with a personal responsibility and peer pressure accountability. Thank you very much.
Henry, thank you very much. That was really interesting, and lots of things to think about then. I suggest we go straight on to Professor Ricardo Bernard, and then we'll have some questions about the Uruguay situation before moving on to Melinda Frost from WHO. Professor Ricardo Bernard is a psychiatrist, and he's Emeritus Professor of the National School of Medicine in Uruguay. He's also a member of the Scientific Advisory Group that was appointed by the Uruguayan president to address the COVID-19 pandemic. Ricardo, welcome.
Yes, I am trying to share the screen. Can you hear me?
We can hear you. Okay. I think you're now starting to screen sharing. Yep, very good.
Well, I want to thank the invitation, and thanks also my friend Henry Cohen for introducing the situation in Uruguay. And I would like in my 5 minutes to focus on one question that I think that it is also interesting for BESI proposal of contributing to the situation from a different perspective. I come from the field of the mental health science, and the first month of pandemic, the challenge were, first, we helped to create a helpline, a telephone helpline for COVID-19 victims or people afraid of. We try to maintain the mental health basic care, and I think it's part of mental health, the responsible freedom that Henry talked as the official position of the whole population in Uruguay is also a mental health asset. That means to engage people in the fight. Well, that's the first month COVID-19 telephone line. There was many people asking for depression, but a lot from anxiety, loneliness, difficult to take decisions, and fear of COVID. Anxiety and fear of COVID were high. That's a sample of 1,000 cases. It's at the moment more than 10,000 people that have consulted this helpline. Well, from March to November, phone calls first expressed anxiety, and 87% accepted social distancing, and mask and other protection behaviors. November 2020, the phone calls relating anxiety decreased, but we have the feeling that so did personal care. And that's the central question that I want to say. If we need to monitor these variables related with social and psychological and behavioral problems. How to engage people as part of the solution? That's the idea of responsible freedom. That means encouraging voluntary collaboration, using peer influence, promoted shared catastrophic compassion. But are we feeling pandemic fatigue, as the World Health Organization called this phenomenon? And that's the question. Do we need a more accurate knowledge of the attitudes and preference of different social groups? And we do not have this information, and I think that it is a key factor for monitoring the campaigns. Are we facing a denial of personal risk? Because it is not frequent to see masks everywhere. There is a good response of the population still, but not everybody, not in every place, not so sure. It's a phenomenon of resignation. Do some non-vulnerable people prefer to take risks? Do social, economical, and recreational needs prevail? Self-regulation, education, persuasion, coercion, what is more effective, and for whom? So, and I am finishing, the question I would like to discuss in this webinar with you is the suggestion of creation of a center for monitoring psychosocial aspects, a behavior observatory. The observatory is very used to study social phenomena. It's an initiative under study, not yet approved. But the idea is to get the contribution of social sciences to increase, for example, an analysis of sociodemographic data. We do not know exactly the demographic aspects of economical aspects, cultural. We do not have analyzed this kind of data, but they are important because this is the people we have to address in our campaigns. Monitoring risk perception. We do not know how is the evolution of risk perception in different social groups. Monitoring adherence to protective behaviors, and analyzing outbreaks as a social phenomenon. We have very clear focus of social in some places of the country, in some social groups, and we would need, I suggest, to study from the perspective of the social sciences, the behavioral mediators and moderators factors of viral transmission from not only a biological, but also a psychosocial point of view. Well, that's all. Thank you very much.
Thank you very much, Ricardo. Now, if anybody has any specific questions about the two presentations that we've just heard, just put your name into the Q&A box, and I think we have one here. Leah, would you like to ask your question yourself? I think you can be unmuted. If not, Lucas, can you unmute Leah?
I cannot. She has to do that on her side.
Leah, can you unmute yourself to ask it? If not, I can ask it. Okay. So Leah says, thank you for your presentation. Were you able to establish the number of individuals who already had a diagnosis of anxiety and depression prior to COVID to better understand the additional effect of COVID on these individuals? That's Leah Avery from the UK. So I think this is one for Ricardo.
Ricardo, ¿entendiste la pregunta, Ricardo? You understand,
No,
Ricardo?
en este momento no oí bien, se cortó.
Okay.
The question, please.
Yeah.
Está escrita en el cuestión ahí de las preguntas y respuestas, abajo y a la derecha. Abajo y a
Oh,
la
chat.
derecha. Okay, you will write, sorry to speak a little in Spanish. Sorry, all of you.
Yes, thank you for help,
Okay.
but I can see the answer and questions. Yes.
You can read the first question.
There are two questions. No.
Just one, which was really about how much anxiety and depression there was before
the question
COVID.
before no, we don't have the a monitoring comparing numbers. We can't do that because this line was new. Now the idea is that it will be probably something to keep because it is very useful for people who have personal crisis. But we don't have numbers to compare, and that's the idea for creating an observatory. Regarding suicide, we don't have yet the numbers of the whole year, but up till July, the numbers have slightly decreased. But the phone calls to the hot telephone line for suicidal ideas have increased 3 times. So more people call asking for help for suicidal ideas, but few people, a little few, were the number of suicide, even if suicide is high in Uruguay. Now, the second question.
I will
Well,
answer.
I think it will be a good idea to wait for the second question until after we've heard Melinda Frost, because it's actually about the issue about whether people become more familiar with risk and therefore adhere less, and the importance of personalizing the potential risk. And I think this is very much the focus of Melinda's work. So if we could, Henry and Ricardo, thank you very much. And if you put yourselves on to, oh, Jeremy, sorry, did you want to say something?
Just that there are a couple of questions for Henry that he actually answered in the Q&A, but I think would be good to at least surface. So potentially the second question from Ray Thomas also will end with Melinda, and it's about the kind of government response. But there's a question from Maureen Smith. I don't know whether Maureen wants to, if we can unmute Maureen, and maybe Henry, you could just sort of give a bit more information than you did in your written answer. It's a very important question. I didn't want it to get lost. So Maureen, I think you can now unmute yourself.
Thanks, Jeremy. glad I got up at 6 a.m. for this presentation because so far it's very interesting. So thank you, Professor Dr. Cohen, for answering my question about the excellent citizen response. I asked if it was good communication, and if you want to comment a bit more on it, I'm also very interested in the concept that you use the concept of freedom to get people to actually follow the directives, whereas in the country that I'm in, the concept of freedom is being used against wearing masks and against following the directives. So how did you flip that? And I'm just very interested in that. Thank you so much.
Thank you, Maureen. Here it's also early in the morning, but not so early. So yes, first, excellent communication from the new president. He's, as you saw, a young president who just began his position and who in his previous career as politician showed some interest in sciences. And he really was transparent. And for him, I saw that in talking to him and in many interviews, really the concept of liberty, of freedom is very important. That is the tradition of Uruguay. Even though we had a military government in the 73 to 85, it was almost the only experience. If you compare that with other Latin American countries, and if you analyze Uruguay as a very progressive country since the very beginning of last century, it was the first country having divorce by only the decision of the woman to abolish slavery. Many important laws that were really socially very important at the first in the continent. So for every single Uruguayan, the concept of liberty, of freedom comes from the bottom of our heart. And that was the main reason why he decided in a very solitude moment, just beginning his presidency, and with the past president, who was from another country and who was a very important doctor also. He was professor of oncology at the same university, at the same hospital in which Ricardo and I used to work. And he was president twice, a very important man, and he was asking for mandatory lockdown. It was a very difficult moment, but he was right. The decision showed that at least in the first months, Uruguay was really an exception. Now we are concerned by the situation, even though we are not so bad as other countries, we are really in risk, and we would like to go back some steps.
Thank you, and thank you for noticing the Q&As. I realize there's two separate columns going on at the same time. One says answered and the other says open. There's two other questions which I'll just mention now, but we'll pick up after Melinda's spoken. One is from Marika Shomeres from Nairobi, who's asking about the history of the synergy between the government and the scientific system, and has that always been constructive? And another one from Ray Thomas, who's interested in what underpins the cooperation of the Uruguayan citizens with the government recommendations. So those are two things that we'll pick up in the general discussion. So thank you for your questions. Thank you very much for your contributions and responses so far, and look forward to more in the second half of this session. So now it's my great pleasure to welcome Melinda Frost. Melinda Frost is Technical Officer at the WHO for Risk Communication and Community High Impact Events Preparedness. And that's part of the Global Infections Hazards work. And she has led risk communication and community engagement capacity building for WHO under the pandemic influenza preparedness, and now is supporting more than 40 countries in building their emergency preparedness and response capabilities. And she's going to talk to us about integrating social and behavioral sciences to support individuals, families, and communities to manage risk in their everyday lives. Melinda, over to you.
Thank you. Thank you, Susan. And thank you, Dr. Cohen and Dr. Bernardi. Really interesting presentations. And it's always, I think, it's really inspiring to hear the work that's being done in countries, because that's what matters the most. So let me just share with you what we've been doing here at WHO in terms of the response for COVID-19 around this area of work. I did pick up on the fact that your seminar series is really focusing a lot on pandemic preparedness. So I thought it might help the viewing audience if I just kind of went back a bit. I don't want to go over the entire history of WHO in this area of work, but just to kind of give you a bit of a framework on how we use social and behavioral science and have progressed over time throughout our different response and management. So this is just a timeline that kind of shows over the past 20 years, all of the different pandemics and disease outbreaks that have been major things that we've been working on at WHO. There's a couple of frameworks. I'm not going to go into detail, but these are the things, these are sort of the cornerstones of how we've been able to build this area that has sort of progressed from risk communication to risk communication and community engagement. And now with more and more addition of behavioral and social sciences and other things that I'll talk about in just a moment. The international health regulations was something that came around as an agreement by all member states around 2005, post-SARS era. And at that point, we realized that communication had to become a key pillar of response, equal to that of lab, surveillance, and so on. So that's one of the key areas that kind of brought about this area of work. And when we began to work in risk communication, we really began to look at some specific areas, systems within ministries of health, internal and external partner coordination. So essentially in a country, that means ministries of health working with ministries of emergency response, working with ministries of agriculture and other NGO partners in country. Public communication, so mass and social media, community engagement with affected populations. So you can begin to see at this point, we were bringing in more direct communication and work engagement with communities, and then beginning to pull in areas of perception of risk, risky behaviors and misinformation and rumor management. More recently, we began the PIP framework. It's the Pandemic Influenza Preparedness Framework. This allowed us to begin then to work more directly with countries to help really build in preparedness frameworks around this area. So with that, we began to work directly with, of course, through our regions. We have 6 regional offices that are quite active in this area, and work with countries to help build their preparedness measures for communication, community engagement, but bringing in the social sciences to help back them up in terms of their preparedness and response areas. So we've been doing this over the past years to prepare for a pandemic, influenza, but of course, all of this work has been very relevant for the response in COVID-19. We were able to do other preparedness work around what we call emergency communications network, where we trained groups, I think over 200 individuals, to be able to deploy out during emergencies and help countries be able to address communication with their population more directly. Spin-off of that program became what we call SocialNet. We did this a couple of years, and we're really just beginning to build this program. We were, again, building up social scientists and behavioral scientists to be able to go and respond during a pandemic. We just kind of started this program, and then COVID-19 helped. We did this primarily in Europe. We're going to expand it to other regions, but we really saw the value of this work play out during COVID-19 in the European region. Now it brings us to today in the COVID-19 response. And within just 11 months, we've seen an increase in several different areas of work that have really built the background and the backbone of preparedness and response in this area. We now have more data than ever. It's not perfect, it's not everything, but it's certainly more than we've ever had before in terms of better being able to respond to needs for information and engagement and behavioral response to help us with this and future pandemics. Some of the specific work that we've done with WHO, again, this is a lot, some at headquarters in Geneva, but a lot through our regional offices. Again, there's 6 around the country that can better represent the needs of the countries within their regions. We've done things like perceptions on mask use, contact tracing, more important now than ever, social science background and research done for healthcare worker risks, overall COVID-19 risk perception, trust surveys, perceptions related to recommendations and potential physical restrictions, and just generally information use. So that's growing. That's an area I think that needs to grow even more, but is been pulled in more now than ever. Another new area of work has been what we call the collective service. And this is bringing together the strengths of primarily 3 agencies, WHO, UNICEF, International Federation of the Red Cross, to better be able to work with communities directly and strengthen community-led response and get closer to the community so we understand what their needs are, what their risk perceptions are, and how to address any gaps in the system. There's a framework where we look at information and communication, how people are accessing and using that, their general knowledge and understanding around COVID-19 and the protective measures, perceptions, again, of susceptibility, perceptions of safety in health facilities, perception of risk and stigmatization, and then overall practices, social environments, and the structural concepts that help support this response. We're also redefining actually what community is. We're now beginning to look more and more, we're looking, of course, working with physical, geographical communities, but also communities that have things in common. We're doing a lot of work through communities of young populations. We're working with faith-based organizations and the business sector too, thinking of that as a specific community that share like interests and needs. And then you've probably heard, if you haven't, we're also introducing a new concept of the infodemic, which is basically the overwhelming amount of information, making it really difficult for individuals, decision makers, to find the information they need to make decisions based on their own health and well-being. And with that, we have now more data than ever that can help support our work in this area. Just quickly, how this is playing out in the response itself. We're working through structures to our programs, both at the global level, through our regional office, and getting down to the community level to really support people to become their own risk managers. And we're doing this through several layers for people to consider their individual lives, their lives of their families, their daily journey, where their risks are, and how they can manage risks in their social life as well. We're doing a community engagement package where the entry point is the family, to really help people kind of map out their daily lives, where the risks are, how they can individually mitigate those. And lots of testing around communications and messaging and how these things can play out in their lives. So super quick overview. And I hope it touched on what you were looking for, but happy to answer questions.
That's great, Melinda. Thank you very much. And I'm now delighted to hand over to Jeremy Grimshaw, who will moderate the rest of the discussion.
Yeah, thank you to Melinda, Henry, and Ricardo for a great set of comments and discussion. So we've got time for questions. We've got a couple of sort of questions that I think go to all 3 panelists. I want to just sort of see if anyone's got any specific questions for Melinda before we open it up to sort of engage all 3. If not, can I just get one point of clarification, Melinda? I mean, the work that you're doing sounds like it's amazing. One of the issues, it seems like it's very much targeting the citizen or family and community level rather than the kind of the political or system level. And I'm kind of interested in the interplay between those two, about the extent to which we can promote individual risk management or family risk management if you're in a society where the sort of the government messages are inconsistent or the systems in that society don't help. So maybe you could answer that, and then we'll go to some of the other questions for all 3 of you.
Yeah, your question could not be more timely. Yeah, you pointed out a really important factor that in that sort of ring diagram I showed you, what we have on the bigger picture is sort of a level or a layer of community and then the layer of the government surrounding that, and that those elements really need to come together in policy and practice in order to help the individual. You know, we were missing that part in that description of what I gave you. It is something that WHO, of course, is working on, not particularly out of my shop, but it is critically important that these things come together. And the reason why I say that it's very timely is just actually this morning I was writing an email and sort of sorting out our next programmatic levels and what we're going to do over the course of 2021, and able to really learn how to improve for the next pandemic. And it is that space between the individual, the community, and the government, and how the response, specifically for our purposes, the communication, community engagement response occurred, what can improve next time that we haven't worked on, in the spaces that we haven't worked on. I think some of the things that were mentioned by Dr. Cohen in terms of leadership and communication style was spot on. I mean, the leader of your country was doing exactly what we've always preached, you know, very transparent, really empathetic messages. So it's nice to see that actually what we've been saying all along is really working, but the focus on the policy and how to really make these things happen at a country level, subnational level is critically important. And I think something we need to probably tease out a little bit more.
Okay, so I'm going to open it up a little bit, and I'm wondering whether, Lucas, we can allow Robin Goodwin to unmute. And basically, Robin was asking a question which I think all three of you touched on, about the ongoing challenges of, you know, sort of communication and encouraging citizens to maintain behaviours over the long haul of the pandemic. So, Robin, I think you can now unmute yourself.
Okay, thank you. Can you hear me?
Yeah. Can you say just where you're from?
Thank you very much for really great presentations. No, my question was really just about how you maintain good behaviors. So when people are anxious early on, and then they themselves don't get infected, or they don't know other people getting seriously infected, I think the challenge then is to maintain the positive behaviors over time. And I think possibly one way of looking at this is the whole issue around long COVID, which is becoming more of an emergent issue. So that maybe younger people who are normally less vulnerable, still a certain percentage of those are getting long-term effects. And I'm just wondering to what extent that's becoming part of the messaging that's being put through, to showing that these groups who are relaxing maybe shouldn't be relaxing too much without, of course, creating greater anxiety and greater mental health challenges by remaking people scared. So I'm just, you know, this is the balance, I think, over time now, before at least the successful vaccines.
So you originally asked that for Ricardo. So Ricardo, I'm going to, I think your slide specifically talked about, you know, pandemic fatigue, was it an issue? So maybe do Ricardo, and then I'll ask Henry and Melinda if they've got things to add. So Ricardo, do you want to have a first go at this? And you're on mute at the moment. You're on mute at the moment, Ricardo.
Microfono, Ricardo.
Sorry, yes, excuse me. I think that I would like to answer one question that was first written in the text, that the experience of COVID-19 in Uruguay is for the people more an idea than an experience. As Henry shows, the number of sick and dead people is not high, so it's a kind of ghost in the population. Now, listening to Melinda, I have one question. I agree that there is a problem of information, of transmission of the information to the population, and psychosocial, behavioral monitoring study and study of this phenomena. Do you think that has to be done by the same team that is in charge of the biological aspect of the pandemic, of the medical, or has to be done by a separate monitoring center, observatory, or something like that? It has to be one team or two teams?
So Melinda, maybe you can think about Robin's original question, and also Ricardo's posed you a separate question there. So I'll hand you then, Henry. I'll come back to you.
Thank you, but it's not my topic. So
Yeah.
Sorry, would you mind just rephrasing the question slightly? I think the two different teams.
Yes.
So
One psychosocial, social science, and the other the medical classical.
Ah, okay. Actually, also quite a timely question and something that we're working on in different ways at WHO. I think what we're learning, and learning all the time, is that it's great to really integrate these teams. I can best equate that at what's happening at WHO in terms of our response, where we've had a very biomedical focused response. We have a team on infection prevention and control. We have a group on clinical, we have a group on epidemiology. And then almost separately, we have our behavioral and social science experts. And it's sort of through my work, through risk communication, community engagement, that we've been pulling them in. But I think it's the most success we're seeing is when they can get together and think about these things hand in hand, when our guidance comes out to bring in the psychosocial aspects as the biomedical approaches and recommendations are being done. So while these individuals may sit in two teams, they really must come together for the response to really, help make recommendations that people are going to follow. I mean, that's what it boils down to, right?
Can I ask, just as a follow-up to that, Melinda, I mean, it felt in the early days of the pandemic as though the public health and biomedical dominated, because we were trying to make sense of this, new diseases spreading so quickly. Yeah. And and certainly in my country, it was very much those biomedical or public health tables that dominated. Mm-hmm. And it's taken quite a while for both at our federal and state level to recognize we actually also need to bring in the more psychosocial, the behavioral, the system thinking to do that. And I wonder to some extent whether it's a reflection of the rapid evolution of the pandemic, of a novel virus we knew nothing about before, that really made the medical area dominate. But in the future, maybe we need to sort of, maybe we can learn from this so that we're starting from the gates to say, actually, this is it's also the psychosocial.
Yeah, no, I think you've said that well. And I would completely agree. That's exactly, I would describe what happened at WHO and likely our regional and country offices too, that it was biomedical in the beginning. We really had to kind of sort that out. And then also in the springtime, when countries began to institute physical restrictions, I hate to use that term lockdown, so physical restrictions, then how do you do community engagement? How do you do that part? So that also kind of played into the whole mix of how we approach this. But now, and I think you and many of the other presenters said it, for the forthcoming year, we are focusing almost all on the behavior of this sort of last mile, so to speak. How do we really engage individuals and communities to be able to keep up this behavior until the vaccine is out and able to help people. And there's different countries, different communities have different motivations and different levels of their willingness to do this. It's complex. There's no one size fits all. That's why I think you can see in what I presented, our approach has really been to empower communities and individuals to know what they have to do and then apply it to their own lives, because our top-down messaging is we're way beyond that being effective anymore.
That's great. So there were a couple of questions going back, I think, to Henry's presentation about, basically the relationship between the science and policy in Uruguay, and what seemed to be, actually you describe a very positive relationship that is respectful, etc. You answered Ray Thomas's question, but I'm wondering whether Ray wants to unmute herself and just ask that so you can answer it to the whole group, Henry. So Ray, do you want to just sort of answer your question again? And Marika, I'm seeing this as picking up your first question, then we'll come to your second question. So Ray.
Henry.
Sure. Hi, thank you very much. This has been fascinating. I've really enjoyed listening to the three talks very, very much. I did ask Henry, and he did respond to me about just about that interesting concept about why potentially people are more cooperative, and he did respond about excellent communication strategies and transparencies. But also one of the things that I thought was really interesting, and he did respond, Henry, was about that message about freedom. And I wonder if you could speak a little bit about that again, to just sort of reiterate what it is about freedom from your country's perspective that made that message really quite salient.
Thank you, Ray. I think that it is what I already said, the importance in Uruguayan idiosincrasy, in the history of the country. What we appreciate most is freedom. We know that nothing is possible for the human being without freedom. And we know that every single day when we wake up, the first day, we say it's so good to live in a country as Uruguay. And I would like, if you allow me, Jeremy, there was a very interesting question from a colleague from Nairobi about the relationship with sciences. Is that the moment, Jeremy? Thank you.
Yeah.
That is very interesting for us because as a small country with only 3.5 million inhabitants, we have a very strong national public university in which the students go there for free. They don't have to pay even a cent. And this university is responsible for around 80% of the scientific production in the country as papers, patents, etc. We also have other institutions as the Pasteur Institute that has a branch in Uruguay that has been working really in an excellent level. So the tradition of sciences in Uruguay is very good. Then the other part of the question, it's the relationship with the governments. Around 6 years ago, all the candidates for president had to sign or signed an agreement with the scientists, with the National Academy of Science, stating that if they were president, they will give 1% of the national budget to science. Nowadays, it's around 0.4. So it's very little, even though the results are very good. Nothing happened. During the last 5 years, the agreement was not honored. We remained with a low budget. Now we are living with a new government in this terrible situation of pandemic, in which the economy is also in bad conditions. Let's see what happens in the next 4 years if the country improves in the economy and if this government will succeed to give more budget to the sciences. That is a new and future story, and we will maybe have to wait to see what happens. But anyway, the current situation of the relationship of the government, of the state with sciences has no background in the modern history of the country.
That's great. So I think we've got two final questions we'll try and fit in. So the first is from Raika, but also Matti from Finland raised this as well, which I think was the sort of talking about the idea of community that you're developing, Melinda. So Marika, can you maybe unmute and just sort of ask your question, and we'll see where we get to.
Yes, thank you so much. I'd be delighted. Thanks everyone for fantastic insights. I was really struck by Melinda, by your mention of these new communities, and we've been thinking quite a lot of this interesting shift towards a COVID identity. All of a sudden, very different parts of people's identity become prominent, and they find themselves in communities that they maybe never thought themselves of as being part of before. And I wonder what your thoughts are on this and how this links to the infodemic that you also mentioned, which is, what do we know enough about the various mechanisms in which these people, based on their new COVID identities, actually utilize, understand, and act according to information? Or what is the connection that we need to investigate further? Thank you.
That's a great question, Marika. Thank you. Do we know enough about it? No. Yeah. And I think that's probably some of the things that, we're going to take a bit of time to decipher. However, I will say, like with this new body of work, managing infodemics, in fact, our entire response pillar around communication, risk communication, community engagement is actually called Managing the Infodemic. There's a new, a research body coming out, I think a research blueprint coming out fairly soon around this. I think that's probably one of the elements that's going to be looked at, is sort of how have people identified themselves, how is information shared. I think we're able to better map now. This is, of course, much of it is like through social media to kind of see how messages are shared, who are they shared, how are communities interacting. Yeah, so there's a lot of work to be done there. And we're trying to also, though, balance that and that new insight using artificial intelligence and communication with the fact that, you know, a large portion of our world is still very digitally poor. So we're trying to, you know, continually look at both aspects. So no, I don't think enough is known. Yes, I think that is something that we will continue to work at. And I invite you to go onto our website under Managing Infodemics, and you can find more updated information on how we're moving forward in that area of work.
And can I just follow up? I'm sorry, we don't have time to mute Matthew. And Matthew, I apologize to you, but Matthew's also talking about communities in large cities, large urban areas, and whether, you know, how you conceptualize communities there compared to, say, you know, rural or small villages or whatever else. So, I mean, how are you thinking about communities in those settings?
Yeah, similarly, it's amazing with COVID-19, it's like it's affected everybody, right? Rich, poor, connected, unconnected. So yeah, the communities that we're seeing in very urban areas too are something that we have to snap into. And we have been primarily working through different initiatives that purely focus on city health, environmental health according to urban population. So that's been our way to connect with those. And then again, as I mentioned earlier, making connections around youth organizations, very active youth, employment networks, and always the faith-based organizations as well as healthcare workers, still the top most trusted information resource. So yeah, looking at different communities, we're certainly doing that. It's whole area of work that is, I would say, growing. It's always been there, but we're just looking at it with new lenses today than ever before.
Could I maybe just, you know, last comments from sort of Henry and Ricardo about whether this sense of community or this idea about identifying and working with communities and their social identity is potentially helpful for your thinking about, you know, the next stages in Uruguay. I don't know if either of you want to comment on that.
Ricardo.
No entendí bien la pregunta.
Okay. Es sobre la experiencia de comunidades en Uruguay, trabajo en comunidad.
¿De comunidades cómo? No entiendo.
From my point of view, it would be a topic for a new conference. I have a big experience working in communities in Uruguay and in Latin America with a project born in United States. It's ECHO project. Maybe you heard about, some of you, maybe Melinda. It's a wonderful project for for creation of communities around the medical problems, especially out of the big cities. But we don't have time now. Thank you.
Okay.
Yes, it's too complicated to summarize.
So we need to come to an end. Melinda, one thing, a couple of people have basically were very impressed with what you're doing, is saying, you know, where can they access those resources? So if you can send us a URL, we will tweet it out, and so make sure that you know, people can get all that work.
Okay.
So I'd like to finish by just thanking Henry, Ricardo, and Melinda for what's been a fascinating sort of webinar, which I've learned a huge amount from. And just wanted to remind people that the next webinar is on, Thursday, the 10th of December, the same time slot, when we're going to be talking with African colleagues, in particular about, you know, basically what has been happening in that continent with COVID and what the successes have been. But we've learned a huge amount today from our speakers. So thank you very much. And I think this is the end of the webinar. So thank you.
Thanks all. Bye.
Bye. Thank you.
Bye.
Bye-bye.